Hi guys, it's Laura. Again, just I'm going to give you a quick overview on cancer staging. So we are introduction to cancer staging, the TNM system, other cancer staging systems that are available throughout the world, and kind of future trends, just to give you the definition and importance of cancer staging. So staging refers to a process used by healthcare professionals to determine the extent of cancer that's in a patient's body, and that includes the tumour size and if it's spread. Why is it important to have accurate staging? Well, it's essential for effective treatment planning, guiding therapy options, and actually predicting outcomes for patients. The different staging systems, there are multiple, or there is a basis of TNM, and I'll go through that later, with additional supportive staging aspects that can be employed depending on the patient's tumour. Then we look at standardised communication. So there is standardised language through the TNM staging system, which we're going to look at, and we use it to help, as I've said, about the prognosis, to predict those outcomes for the patients, and to understand the likelihood of recovery from the cancer or a recurrence in the future. So what actually is needed for staging? So to understand the cancer a little bit better, we will look at the patient, their symptoms, what they presented with, if they've had any, because not always do they have symptoms. It's found incidentally on imaging that's been done for another problem or issue, or routine. So we have to look at that as well, and then we look at physical examination. Is there a lump, a bump? Is there something that you can feel or touch? Or is it a nodule on the skin, like in a melanoma or a Merkel cell? Or is it that they've had a symptom of constipation and they found that they've got a colorectal cancer or rectal cancer? Is it a breast lump that's been found on regular routine breast screen imaging? So we take all of that into history and consideration as well. So we will then look at staging imaging, which are imaging tests that can include like CT scans, MRI, ultrasound or PET, to give us as much information about what the cancer is like inside the body, how much of it is it, how big is it, and where has it gone to if it's spread. Sometimes we have to do that by endoscopy, so we may have to go down through the esophagus, or we may have to go down through the bronchus, and that can help us then if we need to look at doing a biopsy as well. But other biopsies can be a fine needle aspiration, or it can be a punch biopsy of a lesion. They can be done as well to look at what the cancer looks like then under the microscope in the pathology lab, and that's what gives us our histopathology. And this is the cancer cells from that biopsy or from a surgery that's happened. Have they had the cancer taken out and looked at, or is it just that it's been a smaller biopsy like that punch biopsy or a fine needle biopsy that's been done? So that will give us more information, and we put that all together to look at where is the tumour in the body, what size is it, has it spread, and has it spread to just lymph nodes nearby, or has it spread to a different part of the body? And then we also look, as I said, about that histopathology. So like in different cancers, say as lung, so there's different specific types of lung. You've got a small cell lung cancer and you've got a non-small cell lung cancer. They're very different in what they look like under the microscope in the lab, but they're also treated differently, they behave differently. And then again, we also have to look at other molecular changes that can happen within them as well. And we look at other pathology tests. So is there any other organ that's been affected? You know, has the patient's colorectal spread to the liver? Now they've got liver dysfunction, because all of that information is needed before we actually treat the patient as well, to give us an idea of what they present like. How you may actually hear mentioned clinical versus pathological staging. So clinical staging is that initial look at the patient, so that physical exam and the imaging tests that have been done that's found the cancer, and whether they've had that endoscopy down the esophagus or down the trachea to look at the lungs, and a biopsy. That's that initial, that gives us a clinical staging of what we think the cancer looks like. And then we have a pathological staging, so that's actually what any surgery shows us. So if the patient makes it to surgery, whether it be surgery up front and then they have adjuvant treatment afterwards, or if we're treating them in a neoadjuvant stage, so they have clinical staging, treatment, surgery, then treatment afterwards, then this is the surgical stage, or the pathological stage. So that's when they've taken the cancer out, whether it's been after neoadjuvant treatment or just at the beginning before any treatment, and that gives us an idea of what it looks like again under the microscope. But it also gives us can differ from clinical staging, because the cancer then in the surgery can show that it's spread more than what we actually saw in the images, and it actually gives us more precise information of what the cancer is doing at that precise moment in time to help us predict treatment response and prognosis. So it's quite important. Prognostic factors that we look at. So this is basically when we get the histopathology back. Initially we look at the grade, which we also call differentiation. So this is crucial because this actually looks at the cancer cells under the microscope, and it tells us how normal they look, or how similar they look to that normal tissue cell. So obviously low grade is a grade 1, so it's well differentiated, so it looks like similar tissues, similar to healthy cells or healthy tissue. Intermediate grade is a grade 2, and that's moderately differentiated, so it looks the cells look a little bit more abnormal. High grade is a grade 3, and that can be poorly differentiated. Cells look very abnormal, so very different to the normal healthy cells they should look like. And then a high grade, a grade 4, is undifferentiated, so the cells look so abnormal that you can't actually tell which cell they've come from. You know, is it a breast cell? Is it a gastric cell? Is it a skin cell? So it's very, very different, and they normally have that quicker growing cancer than a low grade. Low grade's normally slow, takes a while to grow, but whereas the high grade, they're normally quicker growing. Then we also look at the molecular and genetic information, as mentioned, like in the histopathology. So does it come back telling us that there is a driver mutation or a specific mutation on the protein markers on that cancer, which can help us identify targeted therapies? So are we looking at a HER2 positive? Can we give the patient trastuzumab? Are we looking at EGFR or alkaline lung, where we can give them TKI, so tyrosine kinase inhibitors, those targeted therapies? Again, is it breast? Is it ER/PR positive? You know, is the patient eligible just to have hormone treatment, or do they need to have chemo? So that's those questions. But we also look at the biomarkers also to see about the changes that have happened within the characteristic of the cancer. So we understand its complete, what we call morphology, so what it looks like and what it behaves like, to give it the best treatment. And we want to look at, in some instances, not normally up front if it's in the adjuvant setting, but we may in the metastatic setting, genomic profiling to give us more information on a larger panel of testing of any other genetic mutations or changes that have happened in the cancer that's making it grow, that we can then hopefully target with a treatment. And don't forget, we also look at patient factors. So we've got to look at the patient's overall health. What is their performance status, or their ECOG? What comorbidities do they have? You know, how well are they? What other medications are they on? What other aspects have we found through the either imaging or through pathology testing that may impact our treatment options for this patient? So we've got to look at all of that to help accurately stage and treat patients. That you may see is the TNM staging, because it's widely used across the world, and it's based on the tumour size, lymph node involvement, spread to anywhere else. And this is just basically that. So we look at tumour size, the lymph node involvement, and metastases. Has it spread to distant organs or tissues within that patient's body? And then this is just the T category now. this is just looking at the size, so it can be assigned a letter or a number depending on the tumour, the cancer, the type of cancer it is. So sometimes the T is the primary tumour. Where is the primary tumour? Can we find the primary tumour? We may not, but we've biopsied a lymph node and it's come back as a gastric cancer, but we can't find a tumour in anywhere in the stomach. So this is where we get the T staging. So that would be a TX if we can't find the primary. Can't be measured, sorry, and then T0 if we can't find it, if there's no evidence of it. And then we've got in situ is just starting to grow into the layers, but then after that we assign the other numbers to it for the size of the tumour if we can measure on imaging tumour if it's able to be found. The N stands for lymph nodes. So we give it an N category again with a letter and or a number depending on the amount of lymph nodes that are involved. So the higher the number, the more lymph nodes. And then we look at the size and location of any lymph nodes beside the primary tumour, which determines the lymph node category. And that's the N staging. And then we look at the M. So that's actually for metastases. So is there any distant spread of the cancer or is there not? And if there is, then we assign that number again. And in most cancer staging, there'll be more than M1. There'll be multiple letters and numbers now, as we know that cancer staging systems have been changing over the years. So it's each individual cancer staging system that we look at to help diagnose that overall staging, which is this. So basically, really, we look at the TNM, and this is just using a breast cancer example. So a PT2, which is a tumour over 2 centimetres but less than 5, they have got 1 to 3 positive axillary nodes, and the P is the pathological, so that's after they've had their surgery, and they may have a PY, and that's normally after neoadjuvant. So there's little acronyms used as well depending on when the staging has been done for the patient. So sorry, a PN1 is that 1 to 3 positive lymph nodes. This patient had no metastases, so when we look at the breast cancer staging, this equates to an overall stage 2B. So you may hear patients saying I've got a stage 2B, or they may say my tumour was 3 centimetres. You know, every patient takes information that they can digest and understand, and that's what they run with, and that's absolutely fine for them as long as they understand what it means to them, and then we get an idea. But we can look through notes, we can look through histopathology results and reports, we can look at documentation from the medical oncologist or the radiation oncologist or the surgeon as well to give us an idea of what we're looking at with the overall staging. And then just another example would be a PT3, which is a pathological tumour over 5 centimetres. The N2A shows 4 to 9 positive axillary lymph nodes. Again, no distant metastases, so no other spread. And this actually gives an overall staging of 3A for this other breast cancer example, just to include that to give you an idea of what we look at when we're staging someone, to tell them what their cancer stage is, to then look at treatment options available for them. So other staging systems with variation. So there's multiple other staging systems, but a lot of them use the TNM as a basis, but then they'll add on other specifics for that cancer. And I just wanted to mention a few of them, really just to give you an idea, not to spend too much time on them. You can read up yourself if you're interested. But in our Hodgkin's and non-Hodgkin's lymphoma, there is a Anna Bohr or the Lugano classification, and this is using the TNM for a stage 1 to 4. So they base the number on the location of involved lymph nodes, whether the cancer is either above or below the diaphragm, and then they actually use a letter in the staging to classify the stage. And A, there you go, the B symptoms, so that's that weight loss, night sweats, and then have they got the B symptoms, have they not, have they got extranodal involvement, is the spleen involved, or have they got bulky disease? So that's just one. And then we've got the Guillain-Barré, which is for chronic lymphocytic leukemia. So the restaging uses a 5-staging system, but it also incorporates lymphocytosis, lymphadenopathy, organomegaly, anemia, and thrombocytopenia to determine the risk of disease progression. And the BNA is a 3-stage system as well, incorporating a lot of the hematological aspects that you would expect within leukemia. FIGO is for our gynecological cancers, and it's been updated in 2018, so there is some new staging, but just to show you, the staging again is 1 to 4. However, there are other letters assigned to the staging depending on the amount of invasion of the cancer, then also the amount of distant nodes within the pelvis or further, and then that adjacent spread in the stage 4. But they also look at molecular testing to help with the prognosis for the patient, and that's just some of the things tested. We have melanoma, which we don't use the Clark's level so much now, but we still look at the Breslow thickness, and the thickness is mentioned because that shows you the depth of invasion of the melanoma that's actually been found. So that's really important to look at treatment options and surgical management and the margins within the surgery that's needed as well. And we also test an LDH within these patients because we understand the LDH, so we do understand that the lactate dehydrogenase is a strong independent indicator of advanced disease and a poor prognosis. So the higher the LDH, the worse prognosis. So we make sure that this is checked on an individual pathology for a patient having melanoma, because we use it as an indicator. Forward one. They can be normally checked at baseline, and then we check them again after surgery if the patient has an orchidectomy, so testicle removed, to see if they have been affected. So they should normally reduce, it's just how quickly they reduce, but in most cases we don't wait, we start treatment. And this is the prostate. Prostate looks at the Gleason score, so we grade the patient basically based on how the cancer cells look. So we do use like the TNM staging, but then we also take into consideration a Gleason score as well, and it's normally written on their diagnosis just in case you see it, and it might end up being a 3 + 4 = 7, because they're looking at how the cells look, but they're also looking at what the most component of the cells are and how they actually look as well. So they give them a score out of 10. So for our neurological cancers, whether it be brain or spinal cord, they're actually graded versus stage. So and it's from the WHO grading system. So we do have just that grading that's given, because as earlier we talked about grading, but again it's the same really. The grade 1, it's the least aggressive and can be cured with surgery, up to grade 4, which is that quicker growing, more aggressive, looks very abnormal, and has a poorer prognosis. Metastatic renal cell carcinoma, we actually look at the IMDC, and this is what's showing on the screen here, sorry. And this is an international metastatic renal cell carcinoma database consortium score. So they score the cancer to look at how it they think it's going to perform. So they look at risk factors. They score 1 point if present, as in the time from diagnosis to systemic therapy. A Karnofsky performance status is like your ECOG, so it's how well the patient is. Hemoglobin, corrected calcium, neutrophils and platelets, but then they score that and add up the points, and then they put them into a risk group. So favourable risk is 0 with the best survival, intermediate, a moderate prognosis, and poor risk has worse survival outcomes. So just something else that may actually be riding on someone's diagnosis or within their LERA, or it may actually come up on the histopathology. Just generalise, the SEER summary stage system is a database really in America that looks at cancer trends and statistics, and it just looks at that for localised, regional and distant classifications to understand cancer progression. So it looks at diagnoses over the previous year, the incidence of diagnoses in areas, but they also look at prognosticating where they think cancer is going to take off, which cancers are going to start increasing over the next few years, and what we should be doing about it. We are starting to do more databases here in Australia, like the Neuroendocrine Society of Australia are doing a neuroendocrine tumour database, and they're looking at getting that, and we're trying to look at, there's a sarcoma database I think from Sydney as well, and we're looking at there was information about starting a lung database as well. So it's just about that information sharing about diagnoses in specific areas to see if there's anything that can be changed or modified, and it gives us a really good idea of the amount of diagnoses that happens across the world each year to help, as I said, prognosticate what may happen in the future. So kind of future trends, looking at what's going to happen in the future. As we know, we are doing more genomics or genomic profiling, so we are looking at molecular and biological markers, so what shows up in the patient's histopathology, and then what shows up if we do a bigger panel of genes or mutations. How does that look for us, and what have we got available in our arsenal of treatments to be able to treat these patients with, and are the numbers of rarer mutations increasing, or are they not as rare as what they used to be? Are we just finding them because we're getting better at screening, or are we finding them because we are now actually doing genetic profiling? So we're doing Omnico CASP, which is we send a tissue to Melbourne, and there is a huge panel of mutations that are reviewed for within the patient's tissue from their cancer, and we're hoping it comes back with something that we may be able to target if the patient then say fails standard therapies, or it gives us another option if the patient gets toxicities. And not all patients are ever eligible for a clinical trial, but we can't forget about them as well. We are getting better at looking at refining anatomical staging and trying not to have too many additional staging aspects that makes it very complicated, and making sure that that is transparent across the world, so we're all on the same page and we are then getting the right amount of data that we need on diagnoses. Our radiopharmaceuticals and advanced imaging are getting better, so we know that we're doing a lot more PSMA PETs within the prostate space and neuroendocrine tumours, but also we are able to do a lot more radioiodinized ligands in tumours such as the neuroendocrines, but also the prostates as well. There is a lot more artificial intelligence coming in to help with staging on scans and digital pathology to help look at reflex testing of tumours, so that tumours sent away for those genetic changes that we know are very apparent within that specific cancer, so we don't have to ask for it, it's done automatically, so we get the information at baseline. Hopefully, it might take a little bit of time for turnaround, but we normally get it quite quickly, or we sometimes have to harass. We're looking at responses to treatment to hopefully identify any trend in specific cancers that will respond better to one treatment than the other, and a lot of that will does come down to immunotherapy and like PD-1, the scoring PD-L1 to see who we think will respond better to immunotherapy than others, and within the mismatch repair deficient, which is another genetic testing, and that can be within the metastatic colorectal. If they're deficient, they get access to pembrolizumab. So a lot of information gathering on that to see if we can then next one personalised treatment as we go forward, but to look at multimodal staging approaches, which we're really probably doing at the minute, but it probably doesn't seem like that. But we're taking the patient, we're taking their imaging, we're taking their histopathology, we're taking the past medical history, you know, we're taking all of that into effect. If they've had a previous cancer, if they've had previous treatment, what are we, we're looking at all of those. In conclusion, I think really nurses are at the forefront of being patient advocates, as we've always said. We know the patients better sometimes than even the oncologists. We can help to guide treatment decisions. We can't make that decision for them. They have to have informed consent, but we can talk to them about toxicities from treatment, what their cancer looks like, or has it changed. And guys, as you know, any questions, please reach out, answer back on the link on the YouTube page, or send me an email, laura.haley@calvarymater.org.au, or my direct phone is 50171. I'm here Tuesday to Friday. I'm happy to help in any way, so please reach out. All right, have a great day. Speak to you all soon. Take care. Bye.